Assalamu alaikum wa rahmatullah. Thank you for the MHA group for this invitation. I'm Dr. Yassmin, consultant cardiologist, advanced cardiac imaging and adult congenital heart disease. And I will start my presentation about review of cardiac MRI. And actually, my presentation will touch based on the cardiac MRI acquisitions, gadolinium enhancement technique. We will speak about that, and cardiac MRI and ischemic cardiomyopathy, and we will touch base also about microvascular obstruction by CMR and what is the definition of it, and also we will discuss the prediction of ventricular tachycardia by cardiac MRI. What is the data available up to now? And then I will have some brief about the left ventricular aneurysm and the role of MRI for the diagnosis, and also we'll discuss about CMR in acute MI phase. What is the role of it, and what is the current data that help us to choose this cardiac MRI procedure for acute MI. I'll start with the cardiac MRI acquisition, and if we could say as a modality, it is a gold standard MRI for up to now for the right ventricular assessment. It is having a superior acoustic window over the other modalities. So you have patients who are obese and overweight, and they have a difficult echo window. MRI doesn't have this limitation to be the chosen modality. It's free of ionizing radiation, and that's a very good point for patients who are young age and with other congenital heart disease. Instead of having a radiation, CT and contrast, MRI is your choice to go with it. So my MRI acquisition view, I will talk about the basic MRI acquisition flow. And those basic view, it has to be planned during the MRI procedure. But sometimes the congenital patient, you have to have a specific acquisitions and specific change of protocol, because cardiac MRI is not really like cardiac CT. You don't take the whole volume at once and then you have the multiplanar reconstruction. It has to be planned during the acquisition itself. So we will have the long axis. So I will talk about the familiar term, which is the long axis plan, the horizontal long axis plan, the RVOT and LVOT plan, left ventricular and RV chamber view. This is mostly the basic. So I will go back to the specific view, the long axis view, HLA, which is the horizontal long axis, the RVOT and LVOT, which is the right ventricular outflow tract, left ventricular outflow tract. And then we go to the left ventricular regional wall model assessment, which is actually what we do by echocardiogram. And in addition to that, we can do it by cardiac MRI. And then we go to the short axis stack. That's where we assess the right ventricular wall motion assessment. And then we take the RV ejection fraction and regional assessment also for the RV, and also that can happen by the short axis stack. And we can add to that the transaxial stack. So the transaxial view, which is really the in cardiac CT or cardiac MRI, if you are familiar with it, which is the horizontal view. We have horizontal, orthogonal, and coronal views. The transaxial is the horizontal views. And through that transaxis stack, we can more give an assessment to RV free wall assessment and regional differences. This is actually, especially if we plan for the transaxial stack, it's when you have a question about the RV dysplasia or rhythmogenic right ventricular dysfunction, you might add this transaxial stack to your protocol. So this is in brief the protocol. Maybe with the images you can appreciate. We will go with the short axis view coming from the MRI. This is the right ventricle, this is the right ventricle, and this is the left ventricle, and this is the papillary muscle. You could see it here. And then we will plan the 4-chamber view by crossing actually the papillary muscles and crossing the right ventricle inferiorly. very, very low. And when you plan the 4-chamber view, you have to avoid the aorta. Here is the short axis of the aorta. This is the mitral valve. So you do not cross the aorta. Otherwise, this is going to be the 3-chamber view where you can see the aorta. So cross the left ventricle and cross the inferior part of the RV, avoid the aorta, and cross through the mitral valve. This is a small structure over here, is the mitral valve. And one important part when you plan, you have to look at the apex. You could be off axis. So the third thing, you have to look at the apex. So you are putting your cursor planner during MRI acquisition in the left ventricular apex. By these three main parts, you make sure that you did a very proper 4-chamber view. This is left ventricle, right ventricle. This is right atria, and that is the right ventricle, and this is the pericardium and pericardial factor around it. We can have another name for 4-chamber view, which is the horizontal long axis, which is in both is equivalent. So avoid the LVOT, the left ventricular outflow tract. When you do the plan, you have to be careful with the apex. Now you have a very good 4-chamber view. We move to the short axis cine, which is essential in any cardiac MRI acquisition. This is the 4-chamber that we have done and we have acquired, and then we have multi-stack images. You see how many slices I'm cutting. I'm asking the MRI to do, and we will start from the AV groove. And we will be actually parallel to the interventricular septum. This is the interventricular septum over here. And we always get parallel. And by MRI, you can just click on perpendicular, and this is going to give you an axis which is very much perpendicular to your septum. And you slice your ventricle from base to the apex, and this is a very good about MRI because it has a superior acoustic window, especially the apex. You cover the apex beautifully, and you can see all the anatomy of the apex, not like echocardiogram. And when you plan that, you leave 1 centimeter interval between each stack, cine stack. We can do it also by the 2-chamber view, but the best is to be really guided by the 4-chamber view. Now we can change this kind of short axis cine views. We can have it differently, and for the ASD, for example, if we want to have the anatomy of the ASD, we have it multi-stack cine views, and we can have the distance of 0, so we don't miss any gap. Especially with ASD, we don't want to miss anything. This is basically the results of what we have done. This is the multi-cine stack, and then this is you get the short axis view, the left side and the right side. Mitral valve is over here, and you go forward here to the mid of the ventricle. You can see beautifully the papillary muscles here, and then forward to the left ventricular apex. And this is going to be really mostly basically be done by any cardiac MRI scanner. Now we go with the right ventricular 2-chamber view. Again, we go back to the 4-chamber as I explained. And what is it in about the right ventricle? We have to assess in a long axis view rather than 4-chamber only, because we are respecting the RV contraction. The RV contraction is always in the long axis. It's longitudinal, يعني بالطول يتمدد أكثر مما هو ينقبض بمحوري زي left ventricle. Left ventricle, it contracts with 3 different rotators in the left ventricular muscle in the myocardium, but the right ventricle mostly longitudinal, so it's really shortening and lengthening of the RV. So 2-chamber view is very nice to have in MRI. And this is going to be very simple. You cross the tricuspid valve over here, and you have a perpendicular. You have to be parallel to the interventricular septum here, and then you acquire the right ventricular 2-chamber view. The next phase, this is actually after you acquire all of this. This is a basic view, the long axis and short axis view. And then you go to the most important part, which is the phase contrast, and it is the gadolinium-based contrast. All MRI is gadolinium-based contrast, and this gadolinium is a unique, actually, material. It is a large and high-density element. It's a very big one. So unique about gadolinium is it goes into extracellular space only, so it does not cross the myocyte membrane. So any living cells that is viable, the gadolinium is unable to cross those cells. So يعني بما معناه الخلايا الحية أو living myocardium, the gadolinium does not cross it. When the gadolinium is crossed, it means that this area is really a dead area, or there is no viable myocardium. And this is what is unique about gadolinium. Sometimes it's also accumulate in the extracellular space. So when you have an edema and you have like a water filling space, the gadolinium find a very nice place to accumulate over there. And it is also considered as a dead tissue. So the once we see an enhancement remains in the left ventricle, that means that this area is non-viable and it is fibrotic. And this is the beauty of the gadolinium phase. And we go back to the gadolinium dose. It's important to make sure that you are not giving a very low dose or a very high dose. So you have to be between 0.2 millimeter per kg up to 0.3 millimeter in kg divided dose if you have a stress MRI. But a low dose, you might really not good. You might not get a very good quality of image. So you have to concentrate on the dose and also the type of gadolinium. My also take on gadolinium. If you look at MRI, we do multiple phases for gadolinium. We do a perfusion phase and an early phase gadolinium, and then the late phase gadolinium. And I believe everybody heard about that. But each phase has its own characteristic and enhancement. If I'm going to explain in this paragraph, this is the gadolinium enhancement relation to time, 1 to 3 minutes, 5 to 2 minutes. So if I have a gadolinium enhancement, the first minutes or the early minutes, I will have the blood pool very much enhanced. And I will have also the normal myocardium also a bit enhanced in the early phase. And the ischemic part is not that much absorbing the gadolinium. And then afterward, if I waited for more than 2 to 3 minutes, you can see that there is a rapid wash out of of gadolinium from the blood pool and the normal myocardium. And the ischemic myocardium is still remaining gadolinium, and it is very slowly washing out. So the wash out of the gadolinium is going to be slow. And if you see, like, this is the black phase here, this is the MVO, which is a microvascular obstruction. This is a very dead area. I will explain it in details next slide. This is does not any enhancement, and it is very slow wash out of gadolinium. And we will talk about case example in the next phase. So you have to make sure from this slide that in early phases there is a benefit from gadolinium, and the late phase also there is a benefit, and we will study all of that later on. The next and important thing when you have a gadolinium enhancement is the nulling of myocardium. So before acquiring the image, you have to get to the knowledge that in order to take the image, you give the contrast. It's not at any time that you're going to take the images. You have to adjust the TI, which is a very familiar term for the people who use MRI. The TI with the time inversion time. It has to be really adjusted. And I'm talking about that because it's really important for diagnostic images for MRI. Usually the vendors يعني حسب الشركات في شركات تعطيكي هذا الاوبشن في شركات لا فعندك اللي هو يعطوك اللي هو TI scout, which is like an option of which timing that you're going to use. And we have here different examples of the TI scout. So it gives you a very short timing, TI scout of 92 milliseconds. But if you look at the myocardium, it's supposed to be dark and black. So if you are choosing to do the TI, to set the TI at 92 millisecond, you're not at proper phase. So it has to be dark. So if you look at from these all images, which is the darkest myocardium here, you will find it not over there. This is gray, then this is the dark myocardium. This is the best phase I would choose my nulling. So it's around 242 milliseconds. So I will set my TI in the late phase for 240 seconds, and then I will acquire the images. This is for the late enhancement I'm talking about, not for the early gadolinium. The early gadolinium, you just give the contrast and you just take immediately the images, and then for the late gadolinium, you have to adjust the TI according to the nulling of the myocardium. Nulling myocardium, it means that I have to choose the phase where the myocardium is black. Now the contrast is in. يعني احنا هنقلنا هنا contracts already في early phase. بعدين we will wait and look at the TI scout, and this is like not a proper really TI scout. And if I choose again, this is the dark one, and this is the dark, the early, the blood pool, which is bright. I would say that I will start shooting, and I will take images in 242 millisecond and more 100, 270. That's a proper nulling, and this is really important to understand when you start to do cardiac MRI. If you have a bad nulling like this, you will miss really the brightness of the myocardium. It's not going to be a diagnostic imaging. Okay, so now we will move to the clinical part, which is this cardiac MRI and ischemic cardiomyopathy. It's been known and been defined always that the left ventricular systolic dysfunction related to coronary artery disease is a very, very common and presentation, and cardiac MRI is the gold standard for assessing the ejection fraction. The other thing that viability testing is very much accepted by cardiac MRI, and actually the assessment of myocardial viability with cardiac MRI has really very well established through the data. And I will touch base on what is it really the viability and why we ask for it. Successful revascularization defined when I want to refer the patient for CABG or for PCI and he is in heart failure. I have a question whether this patient really benefit from this procedure or not. And then I would ask myself, what is the markers of a successful revascularization? And usually we assess the successful revascularization by global LV function or regional wall thickening. So if I have an improvement in left ventricular ejection fraction, I would say, oh, I had a successful revascularization. If I have an improvement in regional wall thickening, that's maybe a marker of successful revascularization. But actually, that is not really the definition of successful revascularization. It is not an only a functional recovery. And that's why we ask for viability assessment. So viability, it's a non-invasive method by MRI. And unfortunately, it has been studied and well shown by cardiac MRI, but we don't have enough evidence to support the viability as a prognostic value for mortality benefit. And unfortunately, that's what MRI lacking regarding cardiac viability. So the viability actually study what is hibernation, stunning myocardium. The hibernation, which is like a shock, somebody who's shocked actually and really freeze out and cannot do any movement. It's just like a phase that the myocardium goes through it due to ischemia. So if I have an infarct يعني لو صار عندي جلطة وصار ما في أي حركة للميوكارديوم, this is going to give me an answer إنه okay, that's myocardium is already dead. But maybe it's not dead, it's actually ischemic. So it has no really an infarct side, but there is an ischemia. And how can I tell that? Actually, the akinesia, when you do echocardiogram, the akinesia, you see a myocardial wall that does not contract, and it is very thinned out. That's usually what we define by an infarction. But is this actually accurate? Actually, it's not accurate. You can have hibernating myocardium, which is akinetic, and it is viable. And it is akinetic and thinned out because it is ischemic. So this is the viability actually thinking. So wall thinning, if you look at the thickness and the thinned out myocardium in echocardiogram, to assess it actually usually develops as a result of infarction, as I said, and fibrotic contracture. So the area is really shrinked out, but it might be also a result of severe ischemia. This is a well-known fact. So if we take the wall thinning as a predictor for functional recovery after revascularization, this is a really limited prediction. And I will show you from the data, actually. It has a low specificity of the LV wall thinning. So if you measure the left ventricle wall by echocardiogram and you say, okay, this is akinetic area, completely immobile, and it has a more than 2 to 3 millimeters, I would say this is a thinned out myocardium. You're not going to have any benefit from revascularization, but is this a specific indicator? And actually, it is not a specific. So it has a low specificity to predict the myocardial recovery. So 20% of dysfunctional and thinned out myocardium actually has an ischemia instead of a scar. So by echo, you cannot do assessment of the scar. You can see the wall, which is akinetic and thinned out. But you don't know if this is a thinned out because of a scar burden, or is it really because of ischemia? And this is what we talk about in MRI. So they took a very nice study, 1,055 patients with coronary artery disease underwent cardiac MRI for viability assessment. And among those patients, they found patients with the diastolic wall thickness less than 5.5 millimeter. And we consider that it is really quite a bit thinned out myocardium. And then they assess after giving gadolinium the scar extent of the myocardium, and they found that the scar extent was inversely proportional to the regional wall and global improvement. Inversely proportional, it means that the more the scar is there, the less recovery and less success of revascularization. The less the scar is there, the better the outcome. So I would love to have a myocardium with a less scar. It doesn't matter if it's thinned out or not, but this is a good predictor for the functional recovery. And when I have a transmural extent of the scar, that was a very strong indicator of unsuccessful or completely non-viable myocardium. So and this study was very, very actually enlightening to guide you that you don't count on thinned out myocardium, and those might be ischemic, because when you do the gadolinium contrast, you don't find any scar on those area, and actually the thinned out area, they have a recovery after revascularization. So without contrast, you would not be able to tell about the functional recovery, and the viability test by MRI has its value upon other modalities because of that. So as I said, reversibility of myocardial function has been tested, and this is another example actually, the transmural extent of myocardial infarction. So يعني إذا كان الجدار كله of the myocardium is full of scar, is thinned out, خلاص. This is the story that this is really non-viable. But we have different extent, and we will see what is the extent of the viability here. 41 patient has been studied and who have stable coronary artery disease, and they have been assessed by cardiac MRI after revascularization. So they have the revascularization, and they wanted to see what is the likelihood of improvement in contractility among those patients, and they took the hibernation and actually the scarring area. So this is in this chart that they have. If you look at here, improved contractility, the percentage of improved contractility after revascularization، يعني تحسنت الانقباضات في القلب ولا لا. And this is the other chart is the transmural extent of the hyperenhancement, which is per percentage. So 70 to 100%, it means full thickness scar. It's completely scarred 100%. and 51 to 75 and 26 to 50% the transmural scar, 1 to 25% the transmural scar. And if you look at the chart here, it was severely hypokinetic segment, akinetic, dyskinetic. It's completely akinetic. It doesn't have any wall motion. And you look at here, if you look at here, the 100% akinesia and the transmural scar, they have no recovery at all. It's 0% over there. And when they have 75, from 55 to 75%, they have some functional recovery reported and contractility by after revascularization. And then when it is the less scar, 26 to 50%, you have a very good 40% to 45%, more than 50% of the patient is going to recover and have functional contractility. And this is a very nice insight about the role of viability by cardiac MRI. And here's an example I will show you in writing. That's the patient in diastole and in systole before the revascularization and after revascularization. So that was the thinned out wall, which is below that 5.5 millimeter. And in systole, there was some thickening and it was very nice. I mean, I wouldn't say that this is thinned out myocardium if I look at it. And when I look at the contrast, I found that this is all bright. As I said, it shouldn't be there. It has to be dark like the normal myocardium. But this means that there is a scarring. And it is almost near transmural. It is only limited remaining wall, which is viable. So 75 almost near transmural scarring. And after revascularization, you can look at 3 months after the revascularization. This is the diastole, the wall thickness, the functional recovery, and this is in systole. It's almost not contracting. So there was no benefit from revascularization when we have this kind of scar in the myocardium. Here is another example where patient has like a thinned out more than this patient if you look at the thickness here. So it's almost thinned out anterior wall to the apex. And in systole, there is not really that much thickening. And when you look at the MRI, you have just few or maybe subendocardial distant 25% of the myocardium is bright and the rest of it is really dark and viable. I would say this is viable by my MRI. It is 25% scar, not more than that. And after revascularization, actually, when you look at 3 months after that, this is what is the wall thickness became and in diastole and in systole. So this is complete recovery, almost complete recovery of the myocardium. So that's an example of really assessment of the viability by MRI. I will go to the microvascular obstruction, which is a phase actually that we see when we inject gadolinium enhancement. And it is characterized, actually defined by, it is an obstruction. So I would say there is no reflow, there's no flow. There is no blood supply at this area at all. So it is indicated that there was an acute occlusion of the blood supply at one of the coronary arteries. And this has been found when we do MRI. And actually it has a prognostic significance and as a predictor for adverse cardiac event. And I will explain it later on in details. Now I'm going to move to the other part of the use of MRI, apart from viability, which is the prediction of VT by late gadolinium enhancement, ventricular tachycardia. It is a very well-known term, I believe. And what is the role of MRI to have a kind of prognostic or an indicator of the ventricular tachycardia? Actually, it was a very nice study, has been studied. They took cardiac MRI to detect the changes in ventricular volumes and the ejection fraction in patients who are scheduled for ICD. And they took 137 patients. They are possibly going to have an ICD implantation. And they follow those patients for about 2 years, 2 to 3 years. Okay. And the criteria of those patients was that they have an ejection fraction of more than 30%, And they found that when we have a significant scar, more than 5% of the left ventricle, it was a predictor of a high risk of adverse cardiac event. And I will show you the finding of this study. In this chart, you can see that the death or ICD discharge, so that the patient has an ICD shock and VTAC for documented. If you look at those patients, they divided into two categories. The patient with scar, myocardial scar, more than 5%, and they have a high ejection fraction, which is more than 30%. And if you look at the 3 years event rate, it's 32%. So it's quite high percentage. They have a high ejection fraction, but they do have a scar more than 5%, and they have an event rate of 32%. If you look at the patient who has a high ejection fraction of 30% and very low scar, less than 5%, they have a very, very low event rate, which is about 6%. And if you look at the sudden cardiac death or ICD discharge, again, on those patient group, more than 5% scar, more than 30% ejection fraction, it was 27% event rates. And it is very, very low with low scarring below 5% and ejection fraction more than 30%, it was 6%. The incidence of death, myocardial death, it was also reported about 16% in patients with high scar burden, and in patient below 5%, it was 0%. So they did not find any patient who had an event through that evaluation period. And I will show you here in details the details of this study if you are interested to have a look on it. So this is an example of a patient A. He has an ejection fraction of 33% and the scar burden was 22%. And if you look at here, it's very clear. It's most, the whole mid-LAD distally to the apex is really bright. There is no dark myocardium, which is no viability at all. And I would say this is a really high scar burden. And actually, when they did the follow-up for this patient, he really received an ICD shock for VTAC afterward. And if you have another example here, this is a patient with low ejection fraction. It was 28%. It's better than this patient, 33%. And there was no scar at all in my cardiac MRI. And actually, this patient during the follow-up, he did not have any events recorded. The other patient example is patient with a very good ejection fraction, 46%. This patient, obviously, he didn't have any ICD. So 46%, and he has a scar burden of 17%. And that was the scar burden. It wasn't that much big, but it was some scar burden over there. And during the follow-up period, this patient had a sudden cardiac death at 18 months. And then another example, which is a patient again with good ejection fraction, right, 49%, and the scar was 13% scar burden. That was in the right ventricle, so this patient might have an amyloidosis. And those patients had an ICD because of amyloidosis. And actually, in the follow-up period, this patient has received, he has a VTAC and he received a proper ICD shock. So that's a very nice example of this study data that regardless of your ejection fraction, even if it's normal, if you have a scar burden more than 5%, it is more likely that the patient has an adverse cardiac event in the future. Now I will go to a case example of what I have explained to you. This is 4-chamber view for Cine. And this is the left ventricle, this is the left atrium, this is the right ventricle, this is the right atrium. And you can see the myocardium contractility over there, and this is actually akinetic area. There is some abnormal brightness or darkness over the apex, but I'm not going to comment on it unless I see the contrast phase. هنا في الحالة دي حنشوف اللي هو هذا الفيس من غير ما نعطي المريض صبغة. طيب and لو تشوفي هنا تلاقي إنه the right ventricle is contracting very nice, but the left ventricle is abnormal. في مشكلة في left ventricle.
apex.
And yes, for the apex of the left ventricle, you can see that almost akinetic over there.
Yes.
And actually, I can swear by, this is the LED territories. Okay, so distal LED, mid LED, it's not normal. And there is النقطة الغامقة هنا اللي احنا شايفينها. That doesn't go with the trabeculation. Okay, so I have to be careful. بس أنا ما راح يعني we will ما نعطي أي conclusion before the contrast phase. Okay.
Mass for differential diagnosis.
The differential diagnosis is very clear. When you have akinesia at the apex and you see a very dark spot over there, then you have a thinking of a thrombus. Okay?
Yes.
Clot.
Yes.
Okay. And then we'll go next to the two chamber view. This is the two chamber. Left atrium, mitral valve, left ventricle. And you can see this is really very very slow contrast. يعني حاجة غامقة كأنه في دخان في وسط left ventricle صح؟ And this is not really normal that to see. And you can see the distal apex here is akinetic. ما في حركة. And this is also the same for the anterior wall. It's completely akinetic. طيب ما في حركة. Anterior wall is completely stand out akinetic. اوكي واضح الحين شرح في شيء اقوله اكتر.
Go on زي الفل.
اوكي تمام. طيب بعدين هنا اللي هو 3 chamber view, which is you can see the aorta. Once you see the aorta, this is a 3 chamber view. This is the right ventricle, this is the left ventricle, this is the left atrium. And again, I can see the interarterial septum here, sorry, the interventricular septum. And I see this part of the distal septum is akinetic. And I see again this dark brown spot over there. يعني في نقطة كده شايفها. And still it's there. Okay.
Yes.
This is before the contrast. Again, this is the same. And then this is the early gadolinium, which is the first time. So I give the contrast. أعطيته على طول. Immediately أخذت الصور على طول. Immediately within the administration. And this is the best phase that you can see the left ventricular thrombus or RV thrombus or whatever the thrombus that you're looking for. And we see this dark area that we saw earlier in cine images. And we can say from this view, 100% that this is left ventricular thrombus, right? Agree. صح?
Okay.
This is the
Doctor?
two chamber. Yes.
Sorry for interruption. But searching for thrombus after gadolinium enhancement injection in early phase is better than the late one?
It's the only phase that you have to look is the early phase.
Yes, okay.
Okay. And then if you have a fresh thrombus, it might wash out. So you will not see it in the late phase. And then this is the same view, 4 chamber view, but I can't see the real thrombus. But I see here, this is the myocardium. There are areas that is dark, يعني أسود من المنطقة الأخرى صح؟ هنا أسود كتير عن العادي. Okay?
Okay.
This is what we call microvascular obstruction. يعني هنا there is no reflow. المنطقة دي تعرضت إنه صار في acute cut off of blood supply. There was no blood at all. And this is what I was talking about, that this is having a high prognostic value for the future. طيب. This is again the same. The two chamber view, we saw the small dark spot here in the early phase, and this is still there in the early gadolinium. Then I'm positive about LV thrombus. طيب. بعدين we will wait for about 5 to 10 minutes to not 10 minutes, 7 minutes. And then we will do the myocardial nulling as I show you the TI scout. And after that, I will see the late gadolinium enhancement. As I said, all normal myocardium is dark, is black. And the white enhancement, which is the gadolinium, it stays in the area that is dead. This is dead. It should not have any absorption. A normal myocardium does not take any contrast. It is an extracellular. It doesn't take out the contrast. So those myocardium here, they did not take any contrast, but those are part of the myocardium that has all contrast, and this is dead myocardium. And if you look at this, it's almost near transmural scar. So تقريبا أغلب الثكنس أو كل المyocardial wall is taken by contrast. ما عندي أي شيء normal يعني I can't see anything dark over here. So this is near transmural scar from the base of the anterior wall, base to the mid to the apex. So it's all LAD territories. So I would say that this patient has an infarct in LAD territories. And this is the four-chamber view. This is the early phase. Again, I told you about the early phase, and there was some darkness over here, which is the microvascular obstruction. And then when I gave him a contrast, this is the scar. Okay, it's white. Okay, so I have conclusion from this that this patient has an akinetic anterior wall from base to apex. There is an LV clot seen. There is a microvascular obstruction, and there is a near transmural scar form at LAD territories. Those are all the information that we gathered from cardiac MRI. This is a nice short axis view again. You can see at the the papillary muscle mid anterior wall to the anterior septum is completely white, and there is no residual myocardium. So the transmural scar is almost near the transmural scar of this patient, unfortunately. And as I said in my next slide explanation, هنشوف ايش المعلومات اللي هنستفيد منها من المعلومة دي. أول شيء قلنا إنه عنده very high scar burden, so this patient is at risk of ventricular tachycardia in the future. If he has a low ejection fraction, I would expect this patient to have an ICD in the recent future. Now another disease category, which is the post myocardial infarction complication. And what is it? It is the left, sorry, this is not coming, which is the ventricular aneurysmal imaging. The left ventricular aneurysm, actually, it's a very rare, but it is a serious complication. Actually, when we have a transmural infarct that I explained like early on, the area is going to be akinetic and full of fibrosis. If you are waiting for quite, follow-up period of 3 months or 4 months, this area become an aneurysm. An aneurysm, the true aneurysm, that you have all myocardial wall, but it is all like a balloon. I mean, there is no kind contractility. It's a dead myocardium. It is akinetic, dyskinetic. But there is another category, which is the pseudoaneurysm, which is the rupture of the myocardium. So this is the true aneurysm. The definition of it is that you have all myocardial wall intact. Actually, it does happen 10 to 35% post-MI. Sometimes you have patients with Chagas disease, sarcoidosis. They have a myocardial scarring, and they do develop aneurysm. And as I said, it is classified as they are either true or false aneurysm. The true aneurysm, which is it's only a balloon, like يعني تمدد كده قاعد الميوكارديوم ما بيتحرك و full of blood, and it has no shape, so it became like a balloon. طيب, it has all the myocardium thickness and it is protruded, يعني حاجة بارزة كده وkinetic. This is the aneurysm, the true aneurysm. The true aneurysm, which is a scar, like I explained here. This is a normal myocardium. This is a myocardial wall, but this is a scar. It can be, sometimes they offered surgical correction for those patients. And it is usually this kinetic area. It does not contract. This is the definition of it. And then you go to the false aneurysm, which is the more serious complication. The false aneurysm, it's the rupture actually of the left ventricular wall. And this rupture is contained, يعني محتوى يعني مقفل عليه by the adherent pericardium or the scar tissue. So the myocardium is ruptured بس يعني ما فتح على ال pericardial wall, and it is sometimes contained by the pericardial wall, and sometimes part of the fibrotic tissue still covering the false aneurysm. And the diagnostic actually approach is quite challenging, and you have to understand what is each of them, because this one has to need a really surgical intervention if it's possible, and life-saving intervention mostly. طيب نرجع نشوف what is the let me just go there. Okay, the controversial diagnosis, it was proposed that a high neck left ventricular aneurysm is more likely to be the true aneurysm. The narrow neck is the false aneurysm. Actually, this is by echocardiogram, and we're not going to be really picky about that. We can go with the Doppler ultrasound. We can see bidirectional flow, and this also differentiate between true and false. But actually, by MRI, it doesn't have all those criteria. You can have narrow neck, high neck, but you might have also rupture of myocardium. So this controversy about the aneurysm in echo is not the case in MRI. Okay, so I have a case, just a quick case, 63 years old patient, heart transplantation. He came with from outside hospital with acute cellular rejection. It was a suspicious actually, and this patient has a malaise, nausea, vomiting for about a week, and he developed actually diabetic ketoacidosis. He treated with insulin infusion and developed anuric renal failure. And then he developed severe bradycardia, which is unusual for that case, and reported that he did not have any intervention at that time when he has a bradycardia. But we did echocardiogram, and when we did X-ray, that was really surprising that you see the pouch of the apex is protruded out, and there is a flow. Actually, there is a color Doppler flow across that, and actually that patient, out of nowhere, we did not understand why did he have such a thing. By echocardiogram, you might say that this is really true aneurysm because it has a narrow neck or wide neck, I don't know. But actually that wasn't enough to diagnose whether this is true or false. So you go with cardiac MRI. And this is before contrast. And هذا قبل ما نعطي الصبغة. We have the apex here, and we see the pouch. And you see this is the pouch, and there is surrounded by the pericardium. And after gadolinium enhancement, you can see the late gadolinium enhancement. There is a scar of the whole area over there, and almost a loss of the tissue in this distal apex. So it was pseudoaneurysm for that patient. We have another example, 64-year-old patient with type 2 diabetes, hypothyroidism, and he was obese. He came with ST elevation MRI. You can see very small here. ST elevation MRI and the 2, 1, and lateral leads. Okay. Cardiac cath was done for this patient, and if you look at the nice cath, here is the LED, and you can see this left circ here. It is almost occluded. So this patient was treated actually as acute STEMI, and he did MRI in acute phase, and that unfortunately what MRI showed. هنتكلم شوي عشان نكون واضحين. This is the T-star. I did not talk about it because it is more advanced. It's where we see the edema of the myocardium. This is the late gadolinium phase. Unfortunate review. طيب. And when we did the contrast, and we found that there is microvascular obstruction here, dark area, there is some scarring, and it is really bright, almost near to the myocardium, near transmural. Here is the infralateral wall, and you can see also the dark microvascular obstruction here. You can see white scar around it, and then, oh my God, that's near transmural here, sorry. Okay, we cut through this area that is really scarred, and we can see here very clearly This is a microvascular obstruction here. There is almost no blood in this area and surrounded by white scarring in the myocardium. So I would say this is transmural scar with microvascular obstruction involving, it was a very limited, in fact, actually, you see just only the infralateral wall. The LAD and the other territories were free of myocardial infarction. So this patient was treated, and then after that, 2 months later, the patient came with severe chest pain. Same patient. And this is the echocardiogram for this patient. And you see, this is a left ventricle. There's a pouch, very big pouch has been seen here. And there's a Doppler flow across that. They give a contrast, and there is a communication, clear communication between this left ventricle and this pouch. Here's the short axis view of the pouch. So what's going on? We did an MRI or cardiac CT rather than an MRI, and we confirmed that this is really the pouch. But there was some of the extent of the myocardium over there, so it wasn't really a transmural or a ruptured myocardial wall. It's really the true aneurysm. So I'm going to go to the next role of MRI, which is in acute MI, post-acute MI. And so far, the guidelines define that the patient with low ejection fraction after acute MI less than 35%, 40 days after the event, they had to go for an ICD implantation as a primary prevention. But actually, mortality within the first 30 days after MI has been shown to be highest result of myocardial rupture, as I explained earlier. And those patients still have ventricular arrhythmias, and they are no established tool to stratify those patients in the acute phase. Apart from the ejection fraction, we don't have any other modalities. So MRI performed in the acute phase for patient in STEMI, reperfused STEMI. So they have a STEMI, like the patient I explained, and reperfused, and then they did an MRI. They want to understand the changes happened in the infarcted and salvaged or remote myocardium after acute MI and the impact of the MI size. And I believe by our understanding, the higher the MI size, the higher the myocardial event, but we have to prove it. And also they studied the microvascular obstruction, the intramyocardial hemorrhage, and what is the clinical outcomes out of that. So they found out in that study that acute MI size, which is about 30% of the left ventricle, in combination with a low ejection fraction of less than 36% by cardiac MRI, not by echo, in the first week after MI has been shown to have a very adverse predictor, so predict of adverse arrhythmic events in 2 years' time. So if I had the left ventricle of 30% of MI size and the ejection fraction 36%, I would say this patient will have an arrhythmia. And the meta-analysis, which is the largest evidence base of support, the meta-analysis, 2,632 patients. They studied the MI size by MRI and SPECT, and also 10 randomized controlled trial. And they found that MI size has a strong association, 1 year hospitalization. So I know this patient, he's going to be hospitalized in the future. He will have a high heart failure, and he might have a mortality in the future. So unfortunately for our patient, that was the case. And every 5% increase in MI size, there was a 20% increase in hazard ratio in 1 year. So, and what about the microvascular obstruction? As I explained earlier, microvascular obstruction, intramyocardial hemorrhage, associated with a large MI size. So it says to me that this patient hasn't really an acute MI. There is an interruption of blood flow, and might be a large MI size. And I would say that this patient, he will have an adverse left ventricular remodeling. So in the future, he will have an aneurysm, he might have a dilatation, and he might have a heart failure in the future. And this is also shown by meta-analysis of more than 1,000 patients, that the presence of microvascular obstruction is an independent predictor of the major outburst count in the 2 years' time after STEMI and patient was already revascularized. It is really independent. So the presence of microvascular obstruction also has a prognostic value. Okay. This is the example of the microvascular obstruction intramyocardial hemorrhage. Intramyocardial hemorrhage is seen by 2-2 mapping, which is a very advanced technique. It's used in certain research areas. It's not in the only standard scanner. So microvascular obstruction is easy to see, as I explained to you. Very dark black area in the late gadolinium, and sometimes you see it also in the early gadolinium phase. So as I said, the literature support the notion of myocardial obstruction. There is also a notion of what happened what about the edema in acute phase. And this is also a very nice illustration of the salvage myocardium. And what we mean by salvage يعني اللي نجي من المشكلة. salvage myocardium اللي هو اللي بقي سليم بعد الجلطة. Okay. So this is the dark is the microvascular obstruction. الأسود هنا. The white is the scarred, the dead myocardium. And the pink اللي هو salvaged اللي هو still viable. Okay. So this is going to define the myocardial size, the MI size, the late gadolinium enhancement, and the microvascular obstruction. This is the MI size, and the salvage myocardium, which is the rest. So if it's a big MI size, as I said, it's going to have an adverse outcome. I have a case example. 43 years male presented with epigastric pain. He found to have an anterior STEMI with occluded LAD. The left ventricular fraction within 24 hours was 30%. So I know from this that this patient might not have a good outcome. And we want to perform MRI to assess his myocardial size, the myocardial infarction size. And this is the result of the MI, the myocardial size. This is acute MI. You have to know that there is an edema, and it is shown by T2 star. This is really bright, but this is not the gadolinium phase. So I would say maybe this is edema, maybe this is an infarct, I don't know. But then after I give the contrast, this is the early phase. And I can see there is brightness here, but I will not conclude on that. But there is no MVO, there is no microvascular obstruction. And this is the cine, actually, here. So there is some thickness still. And there is edema I saw by the T2 star. And what about the late phase now? This is the cine images again for the same patient. You can see this akinesia over there. And this is the early phase. The two-chamber view ما كان عندي microvascular obstruction, but in three-chamber view, you can see some small dots here, dark soda كده. And this is really a microvascular obstruction. So I saw it in different view. And then this is the four-chamber view. There is some of the microvascular obstruction, which is not a big deal. Now we can see the, sorry, I'll go back. The late phase here. So short axis, you can see almost near transmural scar anteriorly and some microvascular obstruction. So if I have a conclusion, I would say this patient has a low ejection fraction by MRI 30%. MI size is quite large, near transmural anterior, and there is microvascular obstruction. So I wouldn't know from this that this patient almost has no salvaged myocardium, near transmural scar, and he might have an adverse outcome in the next 1 year. And also I would say that he, by the MI size and by the amount of the scar, I did not calculate the scar here because it has specific software to be taken by. But if I have a large scar, this patient might have also a VTAC in the future. So this is a summary actually of all my presentation. And I hope I was clear. And I've shown you the value of cardiac MRI and ischemic cardiomyopathy. First of all, we take a conclusion that in diastolic wall thinning يعني ما نعرف نقيس إنه الميوكارديوم والله أقل من 5 ولا أكثر من 5 is a predictor of functional recovery. It is not. It is a very low specificity. So cutoff of 5.5 has a 94% sensitivity, but it's only 52 specific. So it's not really a good indicator for a segmental functional recovery after revascularization. So it's not going to be guided by that. And we know that the scar extent is inversely proportional to the functional recovery. So the less the scar, the better the recovery is. So the transmural extent of the scar should be the only emphasizing rather than the myocardial thickness. The presence of significant scarring more than 5% in ischemic cardiomyopathy, because other category of cardiomyopathy, they have a different cutoff value for the scar. So the scar of more than 5% identifies a high-risk cohort patient, and the LV ejection fraction more than less than 30%. And the left ventricular aneurysm, it really happens, and you have to keep in mind it's happened 10 to 35% patient after MI, especially patient with acute transmural MI. So as I told you, that patient has a transmural scar, microvascular obstruction. 2 months later, he came with an aneurysm. The meta-analysis, which is a very strong data, more than 1,000 patients, that the presence of microvascular obstruction was an independent predictor of major adverse outcome at 2 years in patient with a STEMI. So if you find a microvascular obstruction, in addition to the scarring, it is really a poor predictor. Acute MI size of 31% of the LV and ejection fraction cutoff 36% by CMR in the first week after MI. This is an acute phase, has been shown to be a predictor for adverse cardiac events in 2 years. And for every 5% increase in MI size, there was a 20% increase in the hazard ratio for 1 year of hospitalization and heart failure and all cause of mortality. And this is the summary of my presentation. Thank you for your attention, and I'm sorry if I wasn't really speaking in Arabic. I hope that most of my talk and knowledge has been understood, and I'm happy to hear any comment or question.